Welcome to the new Retina Radio Journal Club with VBS. I'm Caroline Baumal from New England Eye Center, Tufts Medical Center in Boston, and I'm joined by my colleagues and my friends, Ali Khan from Wills Eye Hospital and Mid-Atlantic Retina in Philadelphia.
Hey everyone, glad to be here.
Vlad Matei in Rocky Mountain Retina Associates in Boulder.
Hello, everybody.
And Christina Weng from Baylor College of Medicine in Houston.
Hi, everyone. Glad to be here.
Tonight, we will be discussing autologous retinal transplantation for primary and refractory macular holes and macular hole retinal detachments, the global consortium. This was a paper authored by 36 authors, in fact. Primary author was Stavros Mosidis and his colleagues, and this was published in May 2021 in Ophthalmology. Ali, can you summarize this paper for us and hit all the pertinent points?
Okay, absolutely. So this was a great paper, global multi-center interventional consecutive series of 130 patients that underwent autologous retinal transplant. That was a technique first proposed by Timur Mahmood back in 2016 and has really taken off both in the US and internationally. And we're learning more and more about it with each publication. And this publication is in that same vein. So they had a total of 130 patients across all sites. And these included primary macular holes, refractory macular holes, and also combined macular hole retinal detachments. And their main outcomes were macular hole closure rate, visual acuity, but then also some OCT-based features, including ellipsoid zone and external limiting membrane band integrity, as well as a new OCT feature, which they describe as alignment of neurosensory layers, which is the alignment of the graft with the rest of the host retina. So they found that, preoperatively, the visual acuity was a mean of 2,500 and postoperative vision improved to 2,250. Vision improved by 3 lines in over 40% of patients and improved by actually 5 lines in approximately a third, 29%. And the overall macular hole closure rate was 89%. They did have a caveat saying 79% of the holes closed completely, while 10% had a small eccentric defect. And in particular, the macular hole RD cases had the highest closure rate at 95%. Safety-wise, there was 1 case of endophthalmitis, 5 cases of graft dislocation, and 5 cases of postoperative retinal detachment. And in some of their analyses of their OCTs, they found that reconstruction of the ellipsoid zone and also the alignment of neurosensory layers between the graft and the host graft and the host area were associated with better final visual acuity. So they concluded that the technique, the autologous retinal transplant, was a great technique in terms of anatomic outcomes with over 89% closure, and functional outcomes were even more interesting with approximately 30% of the eyes getting 5 lines of vision. So another promising publication from this technique.
That's a great summary, Ali. Vlad, what's your quick reaction to this paper?
I think this is an important paper. When this technique was first described, some surgeons in practice had a concern that this would make the OCT look better, but not necessarily improve function. But this paper is a large series which shows a significant improvement not only in the anatomy, but also in the visual functioning. And if you look at just the visual acuity, that may not be capturing all the benefit. I think if you were to do a visual functioning questionnaire on these patients, maybe even more improvement.
Great, that's a great insight. Christina, do you have any other comments about this paper?
Yeah, I think it's really interesting. I mean, 33 of some of the best surgeons around the world. It's great to see them pull those cases together and learn a little bit more about a relatively new technique. I would emphasize that in the vast majority of primary full thickness macular holes, it's probably enough just to stay with standard techniques of ILM peeling and gas tamponade. But we all know that there are certain macular hole types like myopic macular holes, refractory holes, large chronic holes. I mean, I think the average diameter here was over 1,100 microns. Those are tough to close. And it's nice to have a growing number of techniques that we can turn to for those more challenging cases.
Great. We're going to take a quick break. And when we come back from the break, we're going to have a more in-depth conversation about this paper and macular hole repair with autologous retinal transplant. Welcome back to the New Retina Radio Journal Club with VBS. I'm Caroline Baumal, and I'm here with my colleagues Ali Khan, Vlad Matei, and Christina Weng. Dr. Khan just summarized the findings on the global consortium for the use of autologous retinal transplantation for macular hole surgery, and now we're going to have a discussion about the paper. Ali, let's start off with you. Can you give us some instances where you think that it's appropriate to use this technique?
Yeah, I think in this paper, there was even some primary macular holes as well as refractory and macular hole RDs. You know, when I initially heard of this technique, I never thought of using it for a primary macular hole. But they mentioned in this paper that maybe we need to rethink how we stage and describe macular holes, because the average size was, you know, over 1,400 microns in average largest diameter of these holes. So we usually think of a large hole being 400 or more, but this is obviously a different scenario. So I think of now using this technique primarily when the hole is quite large, you know, 900 or more microns. Of this maybe being my first option, but I'm still at the point where I'm using it only in refractory cases.
Vlad, are there any other techniques that you use for a macular hole, and what's your current go-to technique?
So for most cases, I just do a standard PPV with an ILM peel and then gas tamponade, usually SF6. I think if it's a larger hole, greater than 400 microns, or it's more chronic, I might consider using an ILM flap. But in most cases, I haven't had to resort to some of these other techniques like transplantation or like with AMT, for example.
Right. I think in the old days, we used to use plasma and had other things that we used at adjuvants. And now this is bringing a whole different type of scenario, taking a piece of the retina and transplanting it into the fovea. Christina, I know you have some experience with this. Do you think that the piece of peripheral retina that's brought into the fovea, can that function like the typical fovea does?
I think it's an interesting question, Caroline, and we're still learning about it, obviously, because we haven't done that many of these types of cases. But some of the data does support that, yes, it acts like more than a scaffold. And there have been animal models, for example, that have shown ectopic synaptogenesis, where rod photoreceptors from the periphery may potentially be able to synapse with the cone bipolar cells and actually provide some sort of visual function, as was seen here. Now, microperimetry was of limited use in this and other studies, so it's hard to know. But I know of one study in Japan where they looked at patients who had received these autologous retinal transplants, and they were able to detect using microperimetry that there was light detection in that graft piece. So there is some function potentially being generated here, and it's exciting because some of the other techniques that we do turn to, there seems to be more of a growth factor or scaffold function, but there may be more to this than that.
So Ali, when your fellow hears this radio podcast and says to you tomorrow that he wants to do this technique on the patient that has a traumatic macular hole, are you going to teach him how to do this technique? And how do you feel about this with teaching our fellows?
I think first, I think we'd both have to watch a lot more videos on the technique and maybe make some emails or phone calls to people who have had more experience with it. But, you know, I think this paper helps shows that this is a really viable technique in a certain type of patient. And if ultimately there's nothing else to offer the patient, you know, I think it's reasonable. And I think, you know, obviously training fellows, you have to be, as the attending, you know, feeling competent enough yourself. So, you know, that's not a case that's going to be passed right away. But I think the process of thinking about it, you know, this paper highlighted there's more than one way to do this technique. Some people leaving PFO in the eye, some people doing, you know, direct to oil, how to counsel the patient that they're likely going to need 2 surgeries, not just one. I think there's more to this from even like a preoperative planning point of view that's helpful definitely to go with the fellows, whether or not you do the surgery. And then I think once I got more comfortable with it, I think certainly worth teaching in the right setting.
Great. So Vlad, you've perfected this technique. What other disease entities could you envision using this autologous retinal transplantation for?
So I think it'd be interesting to try this in macular holes related to tissue loss, as opposed to just vitreomacular interactions, such as a post-retinitis patient or a macular hole related to MACTEL-2. It's interesting to envision how much of a role in the vision recovery the RPE and choroid play in these cases as well.
Great. I think maybe even for trauma, maybe this would play a role if you could move the retina from one region to the other and it still function. That would be really interesting. And macular degeneration, this is in a sense what we've tried to do. Any other comments? Anyone think that there's any limitations to this paper they'd like to comment on?
I'll mention one, Caroline. You know, there was a good pool of eyes in this series. However, if you look down at the variability between surgeons, it really significantly varied, in my opinion. So some people, for example, looking at the composition of the graft, use just neurosensory tissue, which is what I've done. But others used combined retina, RPE, and choroid as their graft. Additionally, people harvested from different locations, not just superior, inferior, nasal, or temporal, but also how posterior or anterior you were in the retina. And that might make a difference. And then, as was already mentioned, the different types of tamponade. Some people left in short-term PFO, other people used oil, and about 20% used gas. So there's still a lot to learn in terms of what is the ideal technique. And like I said, as more people turn to using this technique for different purposes, we will learn more with time, hopefully.
Correct. It is very difficult to standardize multi-surgeon procedures, and this really hit on that. Ali, do you have any other comments?
No, just applaud the authors and the institutions for putting this together, because without a big series like this, I think it's hard to really get to know and think about these kind of techniques. So certainly made me think more about using it and how I would use it reading it.
Great comments from the panel here. This is Caroline Baumal. I want to thank the audience for listening to the new Retina Radio Journal Club with VBS, and stay tuned for further episodes.